Today we are taking it all the way to the European island, Ireland. Welcome to Medical Experts in Football. I'm Taiwa Deshigbin, a physical therapist and sports journalist. Also, just an update on my life, I'm also working on becoming fluent in Spanish. Mi hablo español. But anyhow, if you are new here, you will not regret coming for the culture, soccer, and sports medicine, or perhaps maybe just to get a good laugh. It is here for you. So our guest today is Dr. Patrick Carton. He's a doctor and surgeon who specializes in the surgical management of the athletic hip joint. But before we discuss surgical topics from hip impingement, hip instability, and preservation surgery for athletes with arthritic hip joints, of course I had to throw in a dab of St. Patrick's Day history, particularly where this holiday first started. And it was in Ireland. Sorry, folks. Sit back and enjoy. Normally I like to talk about culture first. As you see, I'm wearing green, so you might know what I might talk about. So first, to open it up. So St. Patrick's Day is on March the 17th.
That's right.
Just for our listeners, because some of them might not know the history, he wasn't actually Irish. He was actually born in Britain, but he was enslaved by the Irish raiders. And then he obviously did a lot of work with the Christianity. But long story short, the day that he died is known as St. Patrick's Day. For you Irish folks, what is the story that you all have learned about?
Well, I think that there still remains much controversy as to the circumstances as how St. Patrick arrived in Ireland, and some believe he was actually French, not English, and was put on a ship from France and brought to Ireland by I'm not too sure exactly who it was at the time, but yes, when he came to Ireland, he preached Christianity and was famed for getting rid of all the snakes out of Ireland, and to this day we have no snakes in Ireland.
Right, because the weather's so cold, right?
The weather's good. The weather's very temperate here, so it doesn't get too cold and it doesn't get too hot. Although the last few years there's been the weather like around the world seems a bit more mixed, and but we've a very very temperate climate. It's a very easy climate to live in, and down where I live in Waterford, which is on the sunny southeast of Ireland. There's a lot more dry weather and a little more sunshine than you'd get across most of the country. So we're in a small area, almost with a microclimate down here, which is very dry, and so it's makes it much more pleasurable to live here. Many of your listeners may be familiar with Waterford crystal. Waterford crystal is a beautiful crystal glass that's manufactured for years here in Waterford and exported right across the world. You often see it in many a home across the United States of America and worldwide. And that's really where a lot of the crystal has been made in the past, but now mostly just specialty products are made here in Waterford. So that's one of the things it's been famous for over the years.
Interesting. Okay. Well, back to St. Patrick's, because I got to give you my trivia question. So I would like for you to name one of the two cities that happened to first celebrate St. Patrick's in the United States.
Well, if I was guessing, I would be guessing it would be along the East Coast. It would be either possibly Boston, New York, or Chicago.
Wow! Did you do your research? Do you know the story? There's a little story about that too.
No, I don't know. No, you can tell me the story.
Yeah, so I feel like I'm a storyteller right now. I'm a journalist. But yeah, they said that there were some Irish folks that came to New York and they were serving with the British, and they marched a few blocks to this tavern in Lower Manhattan. And then that was the story. So yes, today New York has one of the largest and longest St. Patrick's parade. But now it wasn't until 1903 that you all actually kind of started to observe it as a holiday. What is a scene like there for St. Patrick's Day?
It is. It's well celebrated across the whole island of Ireland, and to a smaller degree in the north of Ireland, but mostly in the south. But I think it's celebrated more actively, actually, in many of the cities around the world. I mean, Chicago obviously paints the river green, and there are a lot of obviously there's an awful lot of people who have ancestors in Ireland who feel very much part of the Irishness and love St. Patrick's Day. there's big parades in many of the big cities. In Dublin, it's an annual parade, but it's also a great community spirit with St. Patrick's Day. You'd have a parade in every town and village across the whole country on St. Patrick's Day, and so it would involve lots of local sports clubs, soccer clubs, GAA clubs, a lot of dancers, and as Ireland has become a much more cosmopolitan type of a lot more people from right around the world live in Ireland, so we get lots of different nationalities now participating in St. Patrick's Day parade, both in Ireland and across the world, which is fantastic.
Yeah, and how do you feel that y'all are celebrating this holiday after us Americans started it?
Or after the Irish who went to America started it. Is that what you meant to say?
All right, all right. Well, talking about USA, because after doing my research, it was saying something about how you folks, we're like your favorite cousins, the Americans. Is that so? And how do you really see us as a country?
Yeah, I think for years we have looked to America for leadership, really, both on the world stage, but a lot of what happens in America very shortly filters through to Ireland. I mean, there's an awful lot of Irish people who have relatives in America, a lot of Americans who feel they have distant relatives or a past in Ireland, and so there's always been that wonderful close relationship with America, and that continues in really every aspect of life. We have a very close relationship with the United States, and we love going there. We travel to the States a lot. The United States citizens travel to Ireland a lot. A lot of they love coming here to visit the counties and of their past and play our wonderful golf courses here in Ireland. So it's a two-way thing, but yes, we've looked up to America in lots of ways over the years, and and there's that closeness there that continues. And on one of the, and also obviously I'm not need to talk about healthcare just right now, but in the healthcare sector, especially more recently, there's been a lot of input into the Irish healthcare from large American healthcare companies, such as one of the companies that I have the pleasure in working with is the UPMC, the University of Pittsburgh Medical Center, and now have a number of clinics and hospitals now in Ireland. So that relationship is booming from a business point of view, from a social point of view, from a personal point of view, and now from a healthcare point of
view. Yeah, and I would agree. I think a lot of Americans, a lot of them say they have Irish descent. So I feel like everyone I talk to, they'll say something like that. So yes, it's a two-way street. But I am curious. You say you all like to travel to the United States. Have you been here before? And what was your favorite aspect?
I have a number of cities. I've been to San Francisco, I've been to New York, I've been to Boston, I've been to Miami, I've been to Atlantic City. I've been to Pittsburgh, of course, and so more recently, and New York many times. So I think there's the difference between what you see in the United States and Ireland. Ireland is it's smaller. The cities are very small. They're not built up. There's a height restriction as to how many floors you can have in Dublin, for example. So we're not used to seeing the skyscrapers, which we simply don't have that in Ireland. And we have lots of greenery, lots of water, lots of rural areas. So when we go to the States and we go to these big cities, it's it's very, very impressive, the architecture and the buildings and how high the skyscrapers go, and so that we've always been a bit in awe of that, even traveling there in our younger days, so there's been this attraction, a lot of kids when they leave college in Ireland have this real attraction to go to the United States. They still feel that there's lots of opportunity there. We have family members who've gone to live in different parts of the United States, in Chicago in particular, and have made a life and a business for themselves there. So there's lots of opportunities we still see in the United States that maybe is a bit more restricted in Ireland for lots of the university leavers.
So if one was to go to Ireland, I mean, certainly they say your pubs is one spot to definitely check out live music, the beer and all that. Would you say more of that nature feeling aspect?
Yes, I mean, there's a big social element to Irishness, and so dating right back to many hundreds of years ago, that we would have always accumulated together in pubs, and the tradition would have gone to mass to the church, and then after the church there would be a congregation of everybody going to the pub. So that the pub because of the rural scene that most people were brought up on, the pub was really an area other than school. The pub was an area, and church. The pub was an area where people would gather and enjoy each other's company, and so that has continued to permeate through generations. And so we love music, and we love meeting each other and having a few sensible drinks. And sometimes you don't want that getting out of the hand. And we often would have great fun till early hours of the morning. And and I think when people come to Ireland, they see that welcoming side of the Irish community. And so we invite really everybody to be a part of that fun and part of that togetherness. And that's very, very clear when you come to Ireland. And most people seem to like that and to enjoy that, and feel they really belong even when they come just for a short time.
Yeah, and from what I have seen and heard is that the people are very friendly and they have a great sense of humor. Now, lastly, for someone that is to come, I want to be sure we clarify one word. So, sorry, what does that actually mean to you Irish folks? Because here, if I tell someone I'm so sorry, I'm deeply apologetic. But for you all, that emotion could be from anger to truly being sorry. Tell me, what does sorry mean to you?
Well, to me, I'm from I'm from Northern Ireland, so sorry to me is the same as you. It's
Okay.
more of an apology, or a little bit of empathy or something. And yeah, it's a commonly spoken word down in the south of Ireland for anything. I agree. And sorry to get your attention, or sorry to. It's quite common when you're out socializing. The people would use the term quite a lot. But for me, I'm like you. It's sorry is more of an element of remorse.
Yeah. Okay. Well, we have something in common. So let's get right into sports medicine, which is why many of my listeners are tuning in. So in Ireland, it seems Gaelic football is the most popular sport. You yourself, were you introduced to football, or what sports did you actually play growing up?
I played soccer, actually. And so the
Football and
and I played yeah, well, we in north of Ireland, the it's slightly different. I mean, the down south, the GAA would be the absolutely predominant sport, and that splits into football, which and hurling, which is like field hockey, except a much faster sport. The ball can be picked up and passed through the air, so it's one of the fastest ball sports in the world, hurling. And so the GAA, the Gaelic Athletic Association, biggest sporting organisation in Ireland, has those two main forms. It also has ladies football and ladies camogie, which is the sort of the ladies version of hurling. And there's really every community in Ireland is involved in the GAA at some level across the country. We have then rugby, and obviously the Irish rugby team have just returned home from the World Cup. A little disappointed to be beaten by New Zealand, but they did very well, and so they were a super team. And we were hoping they were going to go all the way this year, but just didn't happen for them. They didn't get the look in the end. So again, rugby is becoming much more popular over the last maybe 10 years with the success of the rugby team. And then you have soccer. The Republic of Ireland still has a soccer team, and Northern Ireland still has a soccer team. So that's still split up, whereas the other organisations operate across the country as a whole. So in the north, where I grew up, really you played rugby, soccer, or Gaelic, and Gaelic football, that is. And so soccer would be very common up there. It would probably be the main sport. But over the last number of years, Gaelic football has definitely increased as well. And so, and with the advent of Ulster rugby doing well, again, rugby is also a very sought after sport. So I played soccer, but since when I moved to the south, obviously I have 4 children, and they tended to follow me. They went into playing soccer for the local soccer team. So despite in my work as a surgeon, I deal primarily with the Gaelic football and Gaelic hurling, and to some degree rugby and soccer, but my kids would have been following soccer and playing soccer more so than Gaelic. And that's just merely just because probably the history that I played soccer as well.
Well, how and when did sports medicine come into the picture for you?
Well, I've always wanted to be a doctor, I think, from a very young age. And when I went to college in Belfast, in Northern Ireland, I really wanted to become an orthopaedic surgeon. And so I knew that very quickly. And so as soon as I qualified as a doctor, I went into do my surgical exams, and then straight away I went into orthopedics and did my orthopedic exams. So I always had an interest in sports medicine. I enjoyed the whole buzz of trying to not only make people better, but getting them back to a level where they're excelling at their sport. And so when you're working with athletes, you're working with extremely dedicated people. They want to get better. They need to be playing, both physically and mentally and emotionally. It's so important to every aspect of their life. And they're just wonderful people. And right from a young surgeon, I was exposed to quite a lot of sports injuries. And that's the path I wanted to take right from a very early stage as being an orthopedic trainee. And I followed that path directly.
And you said you knew very quickly, despite the schooling being really long, what did you see so early that you knew that real quick that you definitely wanted to be a surgeon?
Early on, I wanted to be a doctor. I saw myself as a general practitioner type doctor, just a community doctor. But when I get into medical college, very quickly, I like the hands-on. I liked dealing with the injuries. I suppose the cleanness of orthopedics and sports medicine. It's very exact, and I'd always had an interest in mechanics and mechano as a child, and so I always was building things and building roads and building buildings, and I also enjoyed architecture. I enjoyed art. And to me, orthopedics is really a combination of those things. It's a combination of engineering, mechanical building, architecture, and art, because sometimes you can view your surgery as an art as well as just a mechanical aspect to it. So you take pride in what you do, and I think you can then see and view your results, which is even more important. So when you create something or you rebuild or fix something, then you get to see the X-rays and you get to look at them and be happy with what you've done. So it gives you an extra little pat in the back at the end. Once the patient's done well, as a surgeon you've done well as well. So I think there's an attractiveness to just the accurateness of orthopedics.
I can see that architecture mindset as a surgeon too, but hopefully at home you're not trying to build everything.
No, at home it's I try to switch off when I'm at home, and so much more I'm into music and obviously a little bit of fitness as well. Not too much, but we try to keep ourselves fit and healthy. But we do enjoy music a lot. So
okay, cool. Well, the Hip and Groin Clinic you created back in 2008. What led you? Because you obviously kind of gave us the layout. You went through your surgery residency. Literally 4 years later, you decided to do that and build a clinic. Did you not feel you wanted to just relax a little bit? I can't imagine residency being stressful. What pushed you to go and create that clinic?
I think my first once I was fully qualified as a consultant surgeon, my first job actually was up in Belfast, and I was employed by a new hospital trust looking after 300,000 or 400,000 people, and they brought me in to try and develop a new unit, a new orthopedic and trauma unit, and so in Craigavon in the Southern Health Trust. So I set up a team of the best managers in the hospital worked with me, and we essentially built a new hospital. And this was for the government, and so in Northern Ireland, and we built a new trauma and orthopedic hospital. We employed consultants and nurses. We designed the wards, designed the theatres. We got them built in, and I became the clinical director of the unit, and I worked there for a number of years. But my real interest was in developing a hip preservation surgery, arthroscopic hip surgery, and I was finding it more difficult to do that within the sort of the public healthcare system in the north. And so an opportunity came in Waterford from a colleague, Mr. Tag O'Sullivan. He was a senior surgeon down in Waterford who I'd worked with in the past, and he basically invited me on a number of occasions to come down and join him in Waterford. And eventually I got to the stage where I wanted to put my practice ahead of my responsibilities as a clinical director and as a trauma surgeon. I wanted to really focus on my area that I felt was niche and to me and rewarding me was really looking after athletes and looking after their hips and the groin area. So I moved down in 2008. I set up the Hip and Groin Clinic. And we started seeing patients really from nothing. So I resigned from my job in the north. Myself and my wife, had to convince my wife to move down, that this was going to be a better move for us. She wasn't too sure at the time. And we moved on. We started really with nothing. And I was self-employed. I went from full-time employment to being self-employed with really no practice and nothing. And we built up our clinic from there. So we just had faith in what we were doing. The surgery I knew was good. I knew we were going to help people, and if we could just keep the surgery winning and getting people back on the field and getting athletes better, that we will eventually build a practice that people would respect, and really that's what we're trying to do.
Yeah, and obviously it's certainly pretty successful. But you're now the director, if I'm correct, the orthopedic sports medicine director. What is your day-to-day like now? Because I imagine you're not doing as much clinical work.
I would say, I'm probably doing more clinical work as it's very hard to fit it all in now. So, but I still work for myself as a fully private consultant in our clinic, and then I work then also for UPMC, the University of Pittsburgh Medical Center, and so as the director of orthopedic sports medicine in Ireland, and that role over the last 3 years has been to help develop the sports medicine network across Ireland on behalf of UPMC. UPMC they have an international reputation for excellence in providing sports medicine care. Originally based obviously in Pittsburgh, and I've been working with the surgeons in Pittsburgh, the senior surgeons there, to try and help replicate and develop a lot of the foundations that they have built in Pittsburgh, and then try to introduce those into Ireland. And so UPMC have purchased a number of hospitals in Ireland. So they purchased the clinic where I was working in originally, the Whitfield Clinic in Waterford. And then they purchased most recently the Sports Surgery Clinic in Dublin, one of the biggest independent orthopedic and sports medicine centers really in Europe, or possibly in the world. It's a fantastic center for them. So my role is really trying to support that, support the network, and developing the physiotherapists within that network, the sports doctors, the surgeons, so we can work as a proper network, offering high quality care to people in their locality, so they're not having to travel across the country to get the best care. That we can really deliver that at home.
Cool. Well, speaking of your interest, like you mentioned, you found an interest in athletes and kind of these hip conditions. You presented, I didn't go to Isokinetic this year, but in 2022, a number of topics about hip impingement and the outcome. So I wanted to talk a little bit about that. So to first open up for our listeners who may not be familiar with hip impingement, would you describe the types of impingement one could experience?
Yeah, hip impingement is essentially a mechanical dysfunction of the hip joint. And so when you're growing, really from birth, your hip takes a certain form, a certain shape. And some people may have a little bit of less cover of the socket, may not cover the ball as much. Other people the socket may cover the ball a little bit more. Some people develop a pelvis that's maybe tilted a little bit more forward. Other people develop a pelvis tilted back. So all these different shapes and morphologies around the hip joint can influence how your hip responds to your environment as you grow up. So if, for example, a 14-year-old is now playing a lot of soccer, a lot of football, and he or she starts developing a slight stiffness in the hip and various things, and a slight restriction of movement, that may be due to the formation of impingement. And that may be due to the socket being a little bit too deep, or the femur becoming a little bit flatter instead of being round, and therefore there's a mismatch when the hip is moving during sport. So it tends to occur a little bit more often in males than ladies, and it tends to be due to abnormalities of the growth plate of the femoral head and abnormalities of the growth plate of the acetabulum, the socket. And therefore, when you're playing sports, there's a lot of pressure on the bones in the hip. The ball is under recurrent strain if you're accelerating and twisting and turning, and that strain pulls on the capsule and pulls on the ligaments around the hip joint that will help shape the bone. The bone becomes prominent. It becomes and then you have this abnormal mechanical contact between the two sides of the joint, which can then damage the cartilage, damage the seal of the hip, which is called the labrum, and then you will get pain, stiffness, and disability. So at the early stages, impingement often can present just with a bit of tightness in the hips. As it becomes a little bit more pathological, then you can get a groin pain. This can be intermittent catching type groin pain, locking, mechanical symptoms, getting up and down from a chair can sometimes catch or lock, and twisting and turning becomes difficult. And then athletes become increasingly more unable to participate in their sports at a high level. Some of our research has shown that symptomatic impingement will reduce your ability to twist and turn, your sprint rate will reduce, your squat depth may reduce, your range of movement starts reducing. So therefore, it becomes more difficult to function at the high levels of athleticism that's required. And then eventually you break down and start getting pain. And that's the stage where really you should be trying to get some treatment. That should be initially conservative treatment, working with your physical therapist or working with your physio to try and remove some of those aggressors in how you train. Avoid your deep squatting with weights, avoid a lot of your shuttle runs. So you can modify the training to try and help the hips. But if the symptoms continue, and you've worked with your strengthening and you've worked with your some of your stretching, it depends on the exact type of impingement. Then if that fails after many months, then really you're looking at potential surgery. So the main type of impingement is pincer impingement, which is a prominence of the acetabular rim, and cam impingement, which is an abnormality of the femoral head neck junction. And most cases you've got a combination of both those impingement deformities.
Now, that was a great layout, by the way. But as a clinician, speaking from like my experience from seeing some of these athletes, I think impingement is a condition that's people are more aware of it. But I've had athletes who will tell me their stories that they went 2 to 3 years and finally got a diagnosis, finally got impingement. Do you feel that from a medicine standpoint, there are still some areas that we as clinicians can improve on, maybe identifying these patients? I mean, you kind of highlighted some of the common symptoms that one may report about and some of the deficits you may see when they're performing their sport.
Yes, I think it seems to go through in waves. In Ireland, I'm not too sure what it's like in the States, but in Ireland, especially in the GAA, the biggest sporting organization here in Ireland, the turnover of physiotherapists and doctors is quite high. So you could have a physio team working with a club or a county, and then in 2 or 3 years' time, then new physiotherapists come in and a new team comes in. And so sometimes you don't get that continuity as athletes are progressing through the ages from 14 up to 16, up to 18, up to 21, up to so and often the progression of impingement is slow. So from year 1 to year 2, you may not see a lot of difference. You might, year 3, year 4, you may have a bit more stiffness, a little bit more tightness, a bit more, but not. But I think if you and therefore when different teams come in every couple of years, it's harder to see that gradual encroachment in their function. And what we do is we try to create awareness by having educational events, conferences. We have a conference now in 2.5 weeks' time in Limerick City, where some of these issues will be again addressed and brought up. There is always that deciding factor is who is suitable for surgery and who should avoid surgery. And and as a physical therapist, you want to try and treat people with a non-surgical route. As a surgeon, you have to make sure that the patients who come for surgery are indicated for surgery. And really, there's been a complete failure of conservative measures before you entertain surgery. But there's very clear evidence that if somebody is presenting with symptomatic impingement that's not improving with the therapy, the longer they continue to play with those symptoms, the more damage they will do to their hip. And when they come for surgery, often the outcome then can be worse. So I'll give you an example. I saw a player, a 23-year-old player, just last week. This is a high-level elite athlete in Ireland, and he'd been managed. He had symptoms for 18 months, where he had stiffness, pain, and a lot of groin pain. A lot of these guys will eventually get groin pain, and it can be then misdiagnosed, as it was in this case, for a groin problem. So people thought this might have been athletic pubalgia or a Gilmore's groin or a sports type hernia. And it was investigated and treated for that. And then it was an MRI scan was undertaken of his osteitis pubis. So this is a central issue with the pubic symphysis. And again, there was an injection given. And so what happened, and this is a very common story with impingement, because impingement has a lot of coexisting symptoms or concomitant symptoms with the groin, with the adductors, with the symphysis pubis. So they're quite often they can go through a lot of different types of therapy and treatment before it eventually gets to a stage where somebody really focuses on the hip and realize that this is where the central problem is. So this guy had 18 months of symptoms, lots of different treatments. Was with a senior physiotherapist for about 6 months, really working on every aspect of physiotherapy, strengthening and activity modification. And really at the end of that was going nowhere. And I came down to the clinic, and when I examined him, his range of movement was extremely limited. I mean, he had maybe 80 degrees of hip flexion. He had no internal rotation, no adduction. Was very uncomfortable in any of this impingement type testing, in that type of provocative movement. And his x-rays had very large cam deformities, large pincer deformities, and he has really considerable articular cartilage damage in his hips. So this is a young guy who is at the pinnacle of his career, and has had symptoms for a year and a half, has continued to train and play during that time, has now come to my hip clinic where he has irreversible damage to his articular surface. Now he will need surgery, because at this stage that it's either give up your sport, have surgery in the hope that correcting the deformities will take some pressure off the hip joint, improve his symptoms, improve his mobility, and that may give the cartilage some time to remodel or to heal. And then it's a close follow-up of this gentleman for the next couple of years to ensure if he does go back to sport, that his hips are not deteriorating anyway. So to me, when I see that, that it saddens me, because I know that had we have seen this gentleman maybe a couple of years ago, or had been picked up even when he was before he had developed symptoms, then maybe prevention strategies could be put in place earlier to try and help him. And this is a very common story I see in my clinic week in, week out. These young guys who come in, there's many males, and but they come in, and many of them have irreversible damage by the time we do surgery. So as a surgeon, you're up against it to begin with, to try and get this guy back healthy, playing well, when you see that level of damage, and it's very common.
Yeah. And as you mentioned, you talked about it being more common in males. Do you also treat the females as well?
Absolutely. The females tend to have a different problem. The females tend to have more instability in the hip. Men and female we're a very different makeup, and we're designed for different reasons. And so the ladies tend to have a lot more laxity in the joints. They tend to have a lot more movement of their hips. So when they're playing sports, they tend to develop a thing called micro instability, where the femoral head has more movement within the joint, and that instability can results in some of the soft tissues, such as the labrum around the joint, it's very important for stability, and the labrum then becomes much bigger as a result of this instability, and then it can start catching. So a lot of the ladies will have stiffness despite having good range of movement. They will feel stiff because when you're playing with instability, the muscles are working much harder to keep that joint stable. Therefore, the muscles feel tight and stiff. And the natural thing is you want to try and stretch out if your muscles feel tight. And when you're stretching out, you're making your unstable hip a little bit more unstable. And you get a vicious circle. So lots of the ladies that we treat, they don't tend to have cam deformities, do tend to have pincer deformities very much around the front of the hip joint as a result of instability. What we do is we remove the small anterior pincer deformity very cautiously, and we repair the labrum and stabilize the labrum to give them more stability. And then the coat around the hip joint, the capsule, we're very careful that we only do a minimal approach to the capsule, and we repair the capsule to maintain stability. So it's quite a different operation than you get with the males. There's a little bit of crossover in both, but the males tend to have stiffer hips with both cam pincer deformities and an element of cartilage issues. The ladies tend to have much more unstable hips, a higher rate of dysplasia. That's an undersized socket, which increases the risk of instability. But both do equally well for surgery. I mean, the ladies do really well when you get the ladies and they have good quality cartilage and you do the repair, they do fantastic. The guys, unfortunately, we do tend to see the guys a little bit later because they develop the CAM deformities at quite an early age, which do a little bit more damage to the cartilage. So, but yes, if you look at all of our statistics it's about 85% male regarding our athletes and 15% female. But the female percentage is increasing every year as I think the education is improving. There's a lot more work in the last 5 to 10 years in Ireland, like the rest of the world, to give the ladies the same support networks as the men have had for years. And when you give that support network and you give the education to the physios who are looking after the ladies teams, then all of a sudden they start understanding the problems and start, rather than giving up the sport, they start trying to manage it better. So we are seeing an increase in the ladies coming through, and they do very well.
Okay. And then going back, you mentioned obviously as a surgeon, sometimes you don't see these athletes until there's been damage to the actual joint. And, certainly we have conservative therapy, but for some athletes, if that damage has been done, will conservative really be effective? So what is your thought process that you have to run through as a surgeon when you are actually deciding, okay, do I need to operate on this athlete like right now, or should I give them conservative therapy even though their joints are already damaged, but they haven't yet tried conservative? What's your actual process?
Yeah, the process is, I mean, it really, depends. Most of the patients who come to me have been through multiple sessions of often different physical therapists. And so a lot of them have had injections, have been with sports physicians. So very rarely would a player ever refer to me that has not gone through that conservative route. Sometimes they do, sometimes they are. And they tend to be the younger guys and ladies who come in maybe in their 14, 15-year-olds. Until they're skeletally mature, I really would not operate on them. And so we'd send them for physiotherapy. I send them into the swimming pool. We have a real belief that swimming is one of the things that can really help restore the function in the hip joint. We do a lot of swimming with holding a float in your arms and your hands. So you're not swimming with your arms, you're swimming with your legs. We use small fins for the feet to try and increase the power being driven through the hip joints. And it's really about strengthening the hip at that young age, where a lot of these 14, 15, 16-year-olds, male and female, are having some degree of micro instability in their hip. That's often the precursor even for some of the impingement. So it's about trying to improve that stability. We teach them not to squat deeply with weights. We teach them, again, no lunging, no deadlifting, although these are very good for strengthening in other patients. When you have this type of symptom, really you should stay away from, because over covering that hip in those positions, especially with weights, will just do more damage. So it's about opening up the hips in the water. We do try to avoid stretching the joint at that age as well. So I don't like doing too much in the way of Pilates or yoga where you're stretching out those hips. I'm perfectly happy to encourage stretching of the muscles, but just not the joint beyond the extremes of passive movement. But always we will trial physiotherapy. We have our own specialist hip physiotherapists in UPMC clinic, and so I will send the patients to one of the guys who will, we've a number of the lady PTs on our ward as well. So any of that team can get involved. And after 3 to 4 months of working with the players or giving them advice, if things are really not improving at that stage, then providing they're skeletally mature, it'd be very rare that I would operate on somebody who's under 17, either male or female, unless they were really absolutely struggling with everyday activities and a lot of pain. Then sometimes you have no choice. But I prefer everything to be skeletally mature if possible. So and most of our practice reflects that.
Yeah. And just like you mentioned, waiting till they're skeletally mature, but in maybe some rare cases where you have to operate, why are you more cautious? Because I imagine that there's probably going to be parents as well listening and wondering, well, why can't we actually operate on these kids?
Absolutely. And the reason is because of the growth potential. So when you remove bone from the acetabulum, I believe there's a much higher growth potential in the skeletally immature. So quite often your deformities can grow back again. And so especially on the acetabulum, there's not a lot of literature out there that has real strong evidence for regrowth of deformity, and but it does happen, and so you can remove the pincer deformity on the rim of the acetabulum, and you can take an X-ray 3 or 4 years later, and you'll see the pincer deformity right back again. And it doesn't often cause symptoms the second time, and maybe not as big, but certainly when they go back playing sports, the same mechanism of micro instability returns, and so they're still straining their hip, they're still straining their capsule, their ligaments. So these deformities can slowly regrow in the same way as they developed the first time. And so if you operate on these high-level sports athletes too young, you increase the risk of this regrowth happening quickly. Whereas if you leave them until skeletal maturity, until that os acetabuli has fused at the front of the hip joint, that growth plate has fused, then to me, it limits the amount of regrowth, and you're now dealing with a more, I suppose, a more programmed approach to the hip. You know what you're going to expect. With the younger kids, with those open growth plates, it's a little bit more unpredictable as to how quickly things can grow back again. So the other thing is that you have they're still growing, the capsule is still developing, the ligaments are still developing, and these are undergo a certain amount of disruption during surgery. So I believe you should try and leave these as much as possible and work with conservative measures. And in my experience, the conservative measures at this age work very well. And we really have very few indications for surgery when the parents are involved and they understand the problem, and they understand quite often these kids are playing 2-3 different sports. So we bring them down to one sporting code. They're training 4 nights a week. You can retrain 2 nights a week. The other 2 nights you get in the swimming pool. So you're trying to restrict the intensity and the frequency of the activities that are causing insult to the hip. You try and knock out some of the aspects of the training that they're doing that are particularly provocative, as I said, such as deep squatting and shuttle runs. If they get caught and they get inflamed, it's straight into the swimming pool. They take an anti-inflammatory for a few days to let any swelling in the labrum, which is often just a little bit swollen, settle down. Often the pain settles down. So when you have a team of physical therapists who work with us in our network, who understand my thinking in that, then they're very happy to work with the patients. And it's about education a lot of the time, and sitting down, reassuring and educating, So, and if the problem continues to return, becomes persistent, becomes disabling, then these kids have a choice either to take a step back to the sport for a couple of years, or to go down the route of surgery. But the surgery really is a last option in my book.
And you brought upon a good point: education, patients knowing the expectations. Now, you as a surgeon, you go in, you do your architecture work on the patient, but then it's really the physiotherapist, the other medical teams that we see these athletes for a longer period of time. And we also have to give our education on what that plan is going to be like. But for the athletes, what educational points do you at least provide regarding to what the process could be like for them to get back to their sport and maybe the future of their hip joint itself?
Absolutely. Well, when the athletes come into the clinic, we always go through the findings of the examination. We go through the X-rays that we take. We go through the MRIs. So we clearly point out the deformities. We try to get them to understand the reasons why they have the problem. We try to get them to understand the reasons why they are now at the point where they may need surgery. We explain the surgery to them. So very often these athletes will often have either a physical therapist or a parent or somebody with them. Quite often we are really encourage somebody else to be along with them. So there's 2 people taking everything in, and so we explain the surgery to them, and really after surgery they will then see our physical therapy team, who will go through a very standardized rehabilitation program that we have developed for our athletes. We believe in getting the athletes moving quickly. So the surgery, they will be up really 4 hours after the surgery, and they'll be on an exercise bicycle. They can start the exercise bicycle from day one, just very low resistance, nice and gentle, just to start getting the hips moving a little bit. It takes about 10 days to 2 weeks for the incisions to fully heal, because there are tracks right down to the joint, and those tracks remain open for quite a long time. Eventually they will heal up enough for you then to get into the swimming pool. So usually 10 days after the surgery, we encourage everybody to be in the swimming pool as often as possible. So in the first 10 days before they get to the swimming pool, they'll be on crutches for maybe 4 days to 5 days. We encourage them just to try and normalize their walking, normalize their gait through that 4 to 5 day period. And at the end of that point in time, they're ready to come off crutches. So the swimming is very much. We just don't like them doing wide rotation in the first 4 or 5 weeks. But abduction's fine, everything forward and back, rotations and extension are fine. So we don't really start the breaststroke in the water, but everything like front crawl and the backstroke, all these type of things are all fine, and we encourage them just to tread water gently in the pool. And the athletes are very good at getting to the water. We really encourage the importance of the swimming for healing of the soft tissues around the hip joint, getting the muscles firing again, and so we review them at 6 weeks, which is usually halfway through their rehab program, and assess the hip to make sure everything's healing well. The muscles are starting to return to strength. The stability is good following the surgery, and if that's all fine, and we're happy with the X-ray correction, then we can, and if they don't have significant damage to the cartilage, then we can start beginning the breaststroke in the water, and we start getting doing some light running. Week 6, we can start running. Week 9 to 10, we introduce sprinting, and then week 12, we review the athlete back again, do a formal clinical assessment at that stage, and if we're happy with everything, then they can return to training. Usually be back playing maybe 2 to 3 weeks, be back playing competitive games after that 12-week review. So it's quite a short period of time really after surgery to be back training, but the hip heals very well, and if with the right program and the right mindset, and the athletes tend to have that, they can progress very well, and usually there's no problem getting back training around 12 weeks after the surgery.
Now, those athletes that may struggle to get back within that time frame, what are some of the most common reasons? Is it maybe due to the cartilage or other things going on in that hip?
Yeah, there are probably two things. First of all, if the cartilage at the time of the surgery is notably bad, I mean, there's a lot of damage to the articular cartilage, then we will deliberately slow the athlete. We will not allow them to run for 12 weeks. Okay, so they'll only begin to do their jogging at 12 weeks. If they have a sufficient amount of damaged cartilage that we're concerned about the integrity of the hip joint, and then these athletes, we would talk to the athletes and say, we would maybe think about the position they play. A lot of them, who are maybe wingers, would maybe move into a more fit midfield role if that's possible. If they or even go back into a defense role, or even into a goalkeeper role, where they're not being subjected to the same amount of outfield trauma to their hip joints. So we tend to review them a little more closely, maybe annually for the first couple of years with X-rays to make sure that the cartilage is not diminishing any further. So cartilage is one thing that will delay progress. There's no question about that. And the other thing that can slow athletes down is the development of scarring or adhesion in the hip joint. So back pre-2013, we would have opened the capsule of the hip during the surgery, and we wouldn't have routinely repaired it. And what we found is that we had a much higher reoperation rate back then for micro instability. We didn't really know much about instability at that stage, but it started becoming more apparent that these guys were functioning well, but were having stiffness in their hip. And when we were examining, we found that the range of movement was better than it was on the non-operated side. And they were having stiffness, and very quickly it became apparent that this stiffness was actually due to instability rather than not removing the deformities properly or anything like that. So very quickly, in a number of centers around the world at the same time, we started realizing instability was a big issue here. So we have to be more careful about the size of the incision we make in the capsule, and we've got to be very careful about restoring that stability by repairing the capsule. So from 2013 onwards, we routinely were repairing the capsule, and in fact, we published a paper looking at a capsule repair in about 500 cases versus non-capsule repair in 500 cases, but about 1,000 overall. So it's the biggest case series in capsule repair published so far. And what we found was that there was a much lower reoperation rate if you repair the capsule. So therefore, adhesions were more common in patients who have some microinstability after the surgery, and adhesions are more common in ladies than they are in men. And therefore, when you're recovering from hip surgery, a little bit more instability, a little bit more movement, the body seems to form these adhesions in an attempt to try and stabilize the capsule and the construct, and these adhesions then can cause pain. So back pre-2013, we had a much higher revision rate to remove adhesions, and the revision rate back then would have been anything around 6-7%, in males, up to 10% in ladies within a sort of 5-year period. And now our revision rate in males is something like 1.4%. It's gone right down to nothing. And our ladies are around 5%. Ladies still tend to be a little bit higher because of that different mechanics of the hip joint.
Now, you and your team, y'all talked about a study at Isokinetic. Because the good thing about, obviously this hip impingement condition is that athletes can continue on to their sport. What were some common findings for those cases of maybe the athletes who did want to return to that high level, but struggle to get back?
Yeah, it's we're about to submit a paper this week, actually, looking at symptoms and symptom burden in athletes and some of the reasons why the athletes don't return to sport. And what the statistics show is that it's about if you look at, there's a difference between returning to sport and returning to your pre-level sport. And so when we look at our return to sport, it is around about in the high 80s. But if you look at the amount of athletes return to where they have considered their pre-injury level of sport, in our clinics around 78%, which is still very high. And but those who don't return to their pre-injury or don't return to sport, we looked at those, and out of all of those, the biggest reason was because there were still ongoing symptoms with the hip joint. Okay, so that was about 25% of athletes say the reason why they didn't return to their sports because they were still having ongoing symptoms. Of that sort of 13% who didn't return to sport, a quarter said it was because of symptoms that were pre-existing. A quarter said it was because of new symptoms that they developed after the surgery around the hip joint that are inhibiting them get back playing sport. And that's most likely some degree of microinstability or adhesion, scarring. And but then there was another a quarter or a third said they didn't return because they could return, but they chose not to, for maybe social reasons. A lot of these guys, they're now a new job, new employment, or they've got they're getting married, or a new birth of a new child. So there's different social reasons why people don't return to sport who could return to sport. And so that was another about quarter. And then the last quarter was they couldn't return to sport because of another injury or another problem elsewhere. So that's how it really breaks up in our clinic, is that so out of 100% of our athletes having surgery, about 78% return to their pre-level of pre-injury sporting. There's about 22% who don't return to that level of sport, but only about 10 or 11% who don't return to sport at all. And a quarter of those is because we weren't able to sort out the problem with the surgery. So it's a very small number where the surgery is not affected to some degree to allow people either to make a choice to return to sport, maybe not quite to the same level before injury, and return to sport with their pre-injury level of. So from that perspective, getting people back to some degree of sport or choice, it's a very highly successful operation. And as you mentioned, the ones that struggle to return to sport or pre-injury, often they're the ones that have some degree of cartilage damage. So when you've damage to the articular cartilage of the hip, there's nothing I can do about that. Okay, so I cannot fix it, I can't repair it, and there's no evidence that there's anything out there across the literature that can help. There's no biologics that can help. There's no PRP that can help, or stem cell treatment. So it doesn't help. So the most important thing about managing a good success from hip surgery, hip replacement, is to have the surgery at a time where the cartilage is healthy. And that requires picking it up early, managing it early, which then goes a little bit against the whole idea of trying to avoid surgery. So you've got that constant battle: is when is the right time to intervene? And so the other controversy then is if you intervene on one side that's symptomatic, but you see exactly the same type of abnormal morphology on the other side, and there may be some cartilage damage developing on the other side, and there's a young male, then a young male or female, young athlete, what do you do? And again, what we do in our clinic is very simple. If the patient is not symptomatic, we do not operate. It's simple as that. And so we educate them. We say the first sign of trouble, it's something that we should maybe review. If you start getting persistent, because often they're much more aware now of their hips, having been through the treatment on one side, and quite often, maybe a year, 2 years later, we do get a call from their medical team or their physical therapist to say, look, he's now developing symptoms on the other side, and maybe it's time we want to move quickly this time and try and get it done before we do more damage. And so there's a sensible approach to individuals, and then I think as a surgeon you have to have that individual approach and a sensible approach. You don't operate on people that don't have symptoms. Don't operate on people that haven't gone through a thorough a program of conservative management. You want to give people a chance to avoid surgery, because a surgery doesn't cure everybody. There are obviously complications that can arise, and so we've got to be very careful regarding our indications. And I think most surgeons who are doing this type of surgery at a high volume for many years, they understand that. You want to have, again, for a surgeon, when you operate, you want to have somebody who's going to be successful, who's going to go out and tell their physical therapists and their doctors, I've had great surgery, it worked really well. And then you're more likely to get more referrals into your clinic as well, so it works. So it's important to operate on the people who need it, and then you get good results, and then you get good feedback from.
Absolutely. Now you mentioned, the cartilage. Once we get to that point, it's damaged. There's only so much we can do. So, and you also specialize in treating young athletes with hip arthritis to help them return to previous sporting activity, whatever you want to call it. Now, I certainly see these hip replacements in older adults. What is a hip replacement procedure like for athletes specifically that you specialize in?
If an athlete comes to me and there is evidence of arthritis in the hip, there are a number of choices. Okay, so the first choice is obviously doing nothing. I mean the athlete may have a chance. This may be an opportunity for him to relook at the type of sports he's playing. Whether this is the right thing to continue doing. And that's the first thing. We have that chat and say, look, is this definitely what you want to do? You want to continue? You have some arthritic change in your hip. This is likely to deteriorate. So a sensible thing may be to move away from this particular type of sport and maybe move into non-weight-bearing sports, swimming, cycling, other things that are not going to do your hip the same amount of harm. So that's a conversation we may have. Often, however, the main reason they're with me is because they want to keep playing their sport. And so the second option, obviously, is your continue with that conservative type of theme. Is there's always they do talk about injections. I mean, would a PRP injection get me back playing? With a steroid injection? What about a stem cell injection? So, I mean, in one of our papers, we looked at a systematic review and did a meta-analysis on biologics in hip preservation, and really there was really no evidence to suggest that they make any difference. And so it's not something that we routinely offer at our clinic based on the lack of evidence to support it. However, hip arthroscopy and hip preservation still has a role to play in athletes who have some degree of arthritis. And we've looked at our 10-year outcome data from operating on patients with established advanced arthritis using keyhole surgery mainly for removing deformities and trying to improve mobility and try to maintain stability of the joint. And so if you remove the deformities that are causing the damage, and you can improve the mobility of the joint, that can have real benefits to the patients, even with some degree of arthritis. And when we looked at all of our patients who have some degree of arthritis who we did this on 10 years later, arthritis is classically graded using the tonus classification, where 0 is essentially no signs of arthritis, where tonus 1 is where you have very mild evidence of the beginnings of some strain on the hip joint. Tonus 2 is where you have established arthritis, but it's not severe. It's maybe mild to moderate. And then tonus 3 is where you have severe arthritis. So when we looked at our tonus 2 and tonus 3 cases, these are the patients with advanced degenerative changes, we found that 67% of our patients with tonus 2 did not require a hip replacement 10 years later. So that's almost 2/3. Tonus 3 didn't fare as well. 25% were surviving without a hip replacement. But overall, this was a significant success for these patients who at that time had a choice, either hip replacement or we try and preserve the hip. And if you've got tonus 2 classification of arthritis, then 2/3 of the patients 10 years later still didn't require hip replacement. And of those patients who didn't require hip replacement, 85%, I think it was 84, 85%, felt still satisfied with their quality of life. So therefore, obviously they're 10 years older, they're now not playing sports, but the main message from that is that correcting deformities can have a remarkable effect on preserving the joint, even when the cartilage is damaged. So, but there are some cases where the damage is more widespread, and in those cases, even preservation surgery has very little to offer. So, when you're talking about hip replacement,
the preservation surgery you're talking about is that keyhole procedure. Is that right?
It's keyhole. I mean, obviously, some surgeons may do it with an open approach, but there's very little that you can do in an open approach that you cannot do in keyhole surgery. Keyhole surgery now is very versatile. We can really work our way around most of the hip, especially the pathological aspects of the hip joint. So everything I do now is through keyhole approach regarding hip preservation. So for those where preservation is simply not possible, then you've got the pain relieving injections, the cortisone for maybe get by some temporary time. But really talking about replacement. And replacement really comes down to two types of operation. You have a hip resurfacing type of procedure where you're using metal components that are you're trying to minimize the amount of bone taken away from the femur, and you use a large cap. So these are large size bearing surfaces that give you a little bit more stability that may benefit the athlete. You then have the more traditional hip replacement approach, where in our clinic we would use uncemented components which are really allow press fit type of component and the bone on growth. We use ceramic on a highly cross-linked polyethylene liner, and we find that this type of replacement again has a very high level of function. It does very well. But the message with any athlete is that once you go down the step of having hip replacement surgery, then again, you have to really look at what type of sports that you're doing. And so, because no matter what you do, it will have a negative long-term effect on the replacement, whether it's a resurfacing or whether it's a standard replacement. So again, often it comes a time for reflection as to whether this is the right approach to continue to play sports. I so often say, look, you can see what's happened to your natural hip. You can only imagine what's going to happen to a replaced hip, possibly at a faster rate. So a lot of our patients do return to sports. They do triathlons, they do Ironman, they do lots of things, but is it the right thing to do, or is it a good thing to do for hip replacement? Probably not.
Well, Dr. Carton, finally, from all your experience, I'm sure there are some up and coming doctors, surgeons who want to also pick your brain. So from all of your experience up until now, what is something you wish you heard earlier in your career when it comes to managing hip impingement conditions?
I think to me, whenever I started doing arthroscopic surgery, I did my first hip arthroscopy in 2004, and the learning curve was very long because at that stage there was very few surgeons doing this type of work, and so that really there was very few people you could learn from, and there was a professor who I worked with who would spend an hour just trying to get the camera into the hip, he would have done 2 of these cases every Christmas. It was his sort of last operating day before the Christmas break, and I used to have 2 hip arthroscopies, and I think he used to drive him crazy. So he brought me in one Christmas, and he noticed that I was able to get into the hip a little bit more easily than he was, and essentially handed me his business of 2 hip scopes every year. So at that time I felt a little bit isolated, and the one thing I was very conscious of was not to do any harm. And that if I was going to take on hip arthroscopy as a practice, that we built it up slowly, and every patient we decided to use a hip scope on back in those early stages, they were well informed about my experience, about obviously we had good intentions, but they don't always work out, and they were always given an alternative to travel to a more experienced surgeon at the time over in London. There was very few around who were doing the surgery. So I was very open, very fair, and I guess that's what I would have liked at that point in time would have been somebody there beside me at those early stages, giving me the advice that's now available for young surgeons, because we have walked the path over these last 20 years. We have made the mistakes. We have worked. We've had our ups and downs, but we've always worked honestly. We've always worked with transparency, and But with the young surgeons now, my advice to them really is to take the advice that's out there, is go to the courses, go to the lectures, go and watch surgeons, do a proper fellowship, learn how to do it properly, and then you can come back and you can safely make a real impact to lots of people who have got real disability with a hip impingement or hip dysplasia. And because I think now we're at the stage where we've evolved over 20 years, the surgery now is precise, the surgery now is very safe, and it's extremely effective. And our results are showing that it's very, very, it's long-term. We're getting long-term success, not just making people better for a year or two while they're playing a bit of sports. It really has. We were always worried, were we doing more harm opening the capsule? Were we doing more harm to the hip removing? But now the results are showing very clearly that we're doing an awful lot of good. And I think, to me, what I'd really like to see is the education on the non-surgical side of things with the physical therapists and the physiotherapists and things to work with us, to come on board, to come and see the surgery, come to our clinics to watch us how we make these decisions. Because I think the more informed the physical therapists are about the indications for surgery, the benefits of the surgery, and the long-term outcomes of surgery, then I think the more they will support the fact that there are cases that definitely need the surgery. And I think the most important thing for a physical therapist out there is to really understand which hips are at risk and need referred early, and which hips are very safe to work with. Because as I say, is if you send a hip down to me to get examined and to get investigated, if it does need surgery, that patient would be sent right back to the physical therapist to work. And so as working as a team is what gets success for the patient.
And I think in life, working together gets you a lot further than working alone. So that was great advice, Dr. Carton. I feel like even though this was the first time I'm meeting you, I felt like I knew you in life. It's been a real pleasure.
A real pleasure being here. And thank you very much for having me. And best of luck with getting to the World Cup and doing your journalism aside with your physical therapy. Absolutely fantastic.
Well, thank you so much. And if I happen to be in Ireland, yes, I will definitely, I don't drink beer, but I'll definitely try it. They say it's different.
Absolutely. And when you're in Ireland, then we can do a live video discussion with the beautiful scenery behind us.
I agree. And then I'll eat. I didn't mention food, but then I'll eat some Irish food with you. Absolutely. And your family. Thank you so much for tuning in to Medical Experts in Football with Dr. Carton. Now, please do me a favor and drop a rating. Give me your feedback so I can keep the great content coming your way.